session being the practice makes practice, a mindful approach for launching clinical students into the stratosphere. And that talk is going to be followed by surgical education from World Series champs, how shared lessons can better prepare medical students. And we will start off with our first group and they'll introduce themselves.
Hey, my name's Adam Baruch. I am an assistant professor at University of Michigan Medical School. I'm an OB-GYN, and this session is something that we've been working that Nick and Anita and I have been working on together. Do you guys want to introduce yourselves?
So my name is Anita Malone. I'm also an assistant professor at University of Michigan. Adam is one of my wonderful partners. And then Nick.
My name is Nick Raja. I'm a second-year OB-GYN resident at U of M.
Cool. So we have this fantastic boot camp for fourth-year students before they become residents. And a lot of it is skill-based, trying to focus on how somebody would transition from being a student to being a resident, making sure that they have the skills to be able to make that transition smoothly and also have an understanding of the content to make that transition smoothly. Most of that training is kind of uniform, like every single student should know how to get a patient positioned on a bed. And in theory, every single patient should be positioned the same, regardless of who the student is who's positioning them. The same is true as far as content knowledge related to menopause or something like that. But then there's this kind of more ephemeral reality of different humans are different. And so different students are different, which means that those students who are different are going to become different residents, different doctors, have different kind of touches and like feels to them, the care that they provide. And so this session, the goal of this is to kind of give students a space where they can kind of explore who they are as clinicians, because obviously Anita, Nick, and I are different people, and so we have kind of different kind of vibes. And I think that there's space to encourage individual students to kind of lean into their specific vibe. Nick, if you wouldn't mind going to the next slide.
Absolutely.
So there's this Jewish prayer that Jews say every morning. And one of the parts of the prayer is Potech et yadecha u'masbielchu charatzon, which means like open up your hand and feed all living things, something like that. And there's this tradition to actually like close your eyes and imagine a hand reaching out who's like asking for something. So you can imagine like you close your eyes and you picture a hand actually. And there's this teaching that if you close your eyes every day and you're like imagining that hand, then you're walking down the street and you see somebody begging for food, like someone's hungry. And then you're like, oh, this is not a new hand. This isn't like some new stimulus, but rather this is the hand that I've kind of been waiting for. This is the hand that every morning I've kind of like been imagining would come out. And then you can kind of like fulfill that imagination in real time and provide that hand food, right? So like you have crackers in your pocket and you're like, oh, these crackers could be for that hand that I've been waiting for. It's kind of like fulfillment of something that you're waiting for, if that makes sense. And so I think that it's similar with training a trainee to kind of be themselves in real time. Like you shouldn't necessarily need to wait until somebody is in a clinical role, until somebody is a doctor, for them to kind of explore what it means to be themselves as a doctor. And so I think that there's potential to create space for students to kind of explore or think about like, who would I be, who will I be as a clinician before they're clinicians, if that makes sense. And so today, what we're going to go through this session. Some of it is like, actually, when we run these sessions, we don't actually show the students these slides. You guys get the back end, kind of, you get to see what we're looking at. It's mostly conversation based. So hopefully we'll be able to lean into some conversation. Obviously, feel free to chip in, kind of like participate. Hopefully we can get some conversation going.
So I'll start us off. And the way I structure this is asking people to kind of think about mentors. This is the way I begin the session with the students. So me personally, I actually came from a performing arts background, never thought I was going to go to medical school. But the way you start to kind of construct your identity as an actor and as a performer on the stage, before you really create things for yourself, you mimic other people. And I think that that's not really unique to performing arts, but you watch and you copy, and then slowly you you develop your own style. And so when I began my clinical rotations, I think there was a lot of intentionality I brought to watching the people around me. And so what I'd like you to do is to kind of think about someone in your mind who you really respect at work. Why do you respect this person? You know, it could be because they are great with patients, or because they're a great leader, or because they're a great speaker, you know, whatever it is about them. And what I want to do is encourage you to think specifically. You know, we have many great speakers in our department, but there's one I think of who I really look up to as a speaker. And I always think that she could sell ice to a penguin. And it's so easy to look at her and say, you know, she is such a provocative, captivating speaker. But what is it about the way she talks and the way she presents herself that kind of makes it that way? So when you think about this person in your mind, what are the specific things that they have done to earn your respect that you might be able to emulate? So one person who comes to mind is I had the privilege of working with one of the chief residents on my OB-GYN clerkship, and her name was Hallie Chrisman, and I had just never seen someone with a bedside manner quite like hers. I mean, all of the things they teach you to do in your first year of medical school, she did every time. She spoke in this low voice. She always met patients at eye level. The way she used or did not use kind of therapeutic touch, the way she addressed people, I just was so captivated watching her be with her patients. And so kind of thinking about all of those little things she brought to her practice really informed the way that I continue to practice now, you know, 4 years after that encounter with her. Does anyone have anything from their own personal experience that they want to share?
Nicholas, I was just thinking about how as you get further and further along into your career, you actually have less opportunity to see how others are practicing. And so when you asked this question, I was like, oh my gosh, I don't even really get to see my colleagues in action as much as I would like to see in, you know, what you're describing in terms of the kinds of behavior you really admire.
And I think that's one of the things I was excited about bringing this session to this conference, because I think that all people who are new in their career, new trainees, med students, residents, fellows, you know, we're all at a place where I think on some level, we're all thinking about these things, whether we are guided through this process or not. But you know, obviously I am new to this job, but I think looking at senior faculty members, people who've been doing this a long time, I think that there are parts of the career now that probably are a little bit more autopilot. You know, you probably don't have to think about the way you're going to bring things to the room every single time you see a patient the way I probably do. And so kind of reimagining that for yourself and getting back in touch with the things that you might do. I don't know.
Dr. Hampton put that, you know, totally when she is able to see her colleagues, that she kind of picks something new up. And then the same, we happen to take call together at Michigan Medicine. So when I watch my partners interact with patients, it's just a really beautiful thing in terms of like, oh, wow, that's a nice way that they do that. And then you learn something every time in that example. And then there are also negative examples. You're like, well, I don't necessarily know if I would do it like that. So that you learn from that, from every encounter essentially, but there's always something to pick up in terms of people who are masterful in the way that they interact. You know, an Adam kind of mastery, a Nicholas kind of mastery. It's a beautiful thing to see.
I've been quick comment. This is Abhishek. I'm one of the fellows at Women and Infants Brown. I just, you know, to echo kind of what everybody is saying, this kind of talk sticks out. It was actually my white coat ceremony, and one of our most favorite attendings gave this talk about how when he was a medical student, he tried to do exactly what you were saying, is sort of pick up, you know, tidbits from this attending, and this attending, and sort of went through each of the 4 or 5 attendings he respected most, and all of them had almost completely opposite styles. One attending there was a lot of like, hand contact with the patient, sort of hugging. Another attending was extremely formal. So I think that there's a lot that you can see in sort of diversity of connection with your patients. And I think that that's been a great part of my training as well.
I think that that's actually, go ahead.
Sorry, Abhishek, what you're describing, I think beneath the surface of this talk is a fundamental question about like, what are we doing as healthcare providers? Obviously, like in my life, I kind of function as a human and I can kind of do what I want, when I want, how I want, if that makes sense. Like as a dad, I can kind of figure out how I want to be a dad. And I take my wife's feelings into account. I take my children's feelings into account. I try to like balance these different kinds of things. I think as a healthcare provider, there's this question of like, I recognize that I'm a servant to the person that I'm caring for. And I recognize that I kind of push down some of my own personal needs oftentimes. The most simple version is that like, I'll be in a surgery that lasts longer than I expect, and then I just don't go to the bathroom. And that's kind of like basic human kind of experience, that like when you have to go to the bathroom, you go to the bathroom, right? And that's something that I kind of take for granted. And then I think about that, to what extent do I push down my own kind of personhood? To what extent should I push down my own personhood in my clinical care? And to what extent do you kind of like play it out? To what extent is what you're describing, like one clinician will give a hug and another clinician is more formal? Are these like therapeutic tools that you kind of sense what the patient needs from you, and then you kind of pull them out to try to meet that individual person where they're at? Or is it okay for you to kind of like just be yourself all the time, and some patients are going to click with you and some patients aren't going to click with you? And like maybe one patient is going to be better served by your partner, who kind of is more or less touchy-feely, more or less formal. I think that I personally don't have a clear sense of that. Like, to what extent should I change according to the emotional reality of the patient? And to what extent should I kind of stably be me? Like, to what extent should I walk into a room where someone's having a miscarriage and kind of like, if I'm feeling happy, like how much of myself do I need to kind of push down? And to what extent is it okay for me to be me throughout the day? I don't have like a clear sense of what my responsibility as a doctor is. And I think that it's interesting when students are kind of making that professional jump into residency, as they're trying to like kind of, for me, these are kinds of things that I kind of just go through throughout the day. And I see that students feel them in a much more acute kind of way. That was kind of long-winded. I'm curious if people have reflections.
I want to say that the other thing that your comment kind of brought to mind for me, Abhishek, is the idea that there are so many different kinds of mastery. And I think Adam will kind of speak to this on a subsequent slide, but you can look at two physicians or multiple physicians and say they are all masters of their craft, but the way that they kind of exert that mastery and the way that manifests in their patient care can be so different for so many different people. And it doesn't mean that, you know, one of them is better than other. They can both be experts at what they do, but that can come out in so many different ways.
I think the next slide kind of speaks to that.
Yeah, I don't want to take up too much time since the time is limited, but this just is kind of a space to talk about that. Similar to what Abhishek was mentioning, there are two senior people in our department. One just retired, Dr. Reynolds, who's like a total formal master, and he's totally formal, and Dr. Vandeven, who has a much softer touch. But if you like saw them kind of in real time, they're totally different, and their patients love them, and they take really good care of people. I think as a learner, it's really important to see these different models, to be like, oh, I don't need to be a specific way. I can kind of like let myself be myself. Yeah, we can go to the next slide so that we don't spend too much time on that.
So the next slide kind of talks about this idea of starting your day in terms of like, you know, what clothes do you put on and what are the external markers of your identity that are reasonable to share. So thinking about, you know, I remember being a medical student, and somebody who's my partner right now, I still remember the dress and I still remember the shoes, and I could admire that, and I could never pull that dress or those shoes off currently. But what is it that you wear, and why do you decide to wear what you want to wear, right? So before COVID, I would actually wear regular clothing to clinic, but I was much more kind of a khaki and a cardigan kind of a person because that's who I am, and it's important for me to be comfortable. I always wear a white coat, and I think the reason I wear a white coat is because of my brown skin, and that's a whole nother different kind of a conversation. But I do need to be comfortable and thinking about, what is it that you put on and what are the clothes that you put on kind of say about you. That's one thing to think about. And then also in terms of like external markers of your identity, my coat is like festooned with like uteruses of various like, bejeweled and things of that nature. And I have, an ovarian cancer pin and the breast cancer pin and the cardiovascular pin. But, is it okay to wear my cross? Because I'm a Christian by my religious religion is Christian. Should people feel okay in terms of wearing a hijab? And what does that mean? And wearing your kippah or not? Like, and then in terms of socio-political symbols, is it okay to wear a BLM pin or a rainbow flag or a pro-life pin? I have a partner who wore a pro-life pin, and there are patients who actually made commentary and chose to like switch, and she was okay with that. But the question is like, is it okay to wear these external markers of your identity, or should those things be kept away? Like I was told not to wear my cross as a resident because it may offend somebody else. But to what extent is that okay? And to what extent, like Adam was alluding to, am I, denying a part of my identity by not wearing the cross, or is it important for me to not to offend so I don't wear the cross kind of when I'm wearing it? Do people have any thoughts in terms of like what they think about in terms of starting the day and what they put on their personhood and what that says about their professional identity and how they came into that, or, and in terms of like the okayness or not okayness to kind of use external markers in terms of like religious symbols or socio-political symbols at all? Any thoughts or questions about that?
I think today, when things are particularly so polarized and heated, and in theory, we're supposed to make a safe space for the patient who's coming for our care. I think that there's like interesting questions about like how much of ourselves. I thought about that during the initial group presentation. I wonder like sometimes what is similar to like how we think about surgery, like what's the benefit and what's the risk of a specific surgery? What are the benefits and what are the risks of kind of like presenting yourself in specific kinds of ways? Which is like an overly simplistic kind of like categorical model for this. But I think oftentimes we take it for granted that there's certain things that you can present. And I don't disagree that like I wear a kippah, like a Jewish head covering, when I'm at work, but I think that there are implications of that. Like the patient who I'm trying to take care of is like curious about what's on my head kind of thing, kind of distracting from the central focus of figuring out what's going on with them.
Oops. I think one way this kind of manifested in my personal life was rotating between different services, my continuity clinic or being on labor and delivery, and then going on something else like urogynecology, let's say, where the average patient is typically of an older age. And I realized one day that I, without really even thinking about it, was finding that I would put my white coat on when I would go into the urogynecology clinic. And when I reflected on that, I think it was because, a 26, 27-year-old fresh doctor am supposed to be providing medical advice to, people who sometimes are my grandparents' age or older, and this aspect of credibility. And I think there was a subconscious part of me that, was maybe unconfident or maybe thinking, who am I to tell this person with so much more life experience, what they should do in any aspect of their life. And I didn't do that. I was much more informal in my dress. I might wear a dress shirt with rolled up sleeves to talk to my, 22-year-old prenatal care patient. And it blew my mind, one, that I did that, but two, that I kind of had been doing it without even thinking about it.
I think this is a really hard topic to talk to students about too. Whenever I'm orienting my students, I'm a clerkship director, and they want to know like what they should wear, and we talk about professionalism. And I think it really there are so many issues. It's really not straightforward. Like you pointed out, Dr. Malone, like the person's their social status has something to do with it too. And women are a lot more vulnerable to dress codes and things like that. And so I think it's never as simple as you think it might be.
I want to take a moment to acknowledge just a couple of the comments in the chat, and then we can move on. One, and I very much apologize if I pronounce names incorrectly, but Pallavi said that that may be important for the physician's self-care, which also should be taken into account, which I think is a great point. Megan O'Connor said the attendings I admired most in residency and still have in my head during difficult cases were the ones with the most outward passion for their work. They were obviously putting the patient's needs above all else, and I've tried to emulate this as much as possible, which is typically a positive thing. So kind of a mix there, thinking of yourself versus the patient. Elizabeth England mentioned imposter syndrome, which I think is huge and kind of speaks to what I was getting at. Dr. Marzano has his hand up.
Well, I was just going to say in regards to, we recently had a student who was wearing scrubs, which is not an unusual thing for our students to wear scrubs, but was not wearing the university issued scrubs, but also was not in the OR. And one of the faculty commented and said, basically they looked like quote unquote nursing scrubs as opposed to doctor scrubs, and that someone should mention something to him about it. And my comment back was, if we have a policy that says you don't wear scrubs, then we shouldn't wear scrubs in the clinic. If we have a policy that you can wear scrubs, you can. And lo and behold, this had not been made clear to the students. So I think it's very important. And again, I knew this student pretty well, and I knew that this was an expression of what he was expressing himself in the way that he dressed. And I was like, you need to be very careful if you're going to go and say that, because, how is that different than someone who wears maybe, a sweater that is maybe not deemed professional because it has different, pictures or whatever on it. And I just think it's a really important in laying out those guidelines at the beginning, especially for the clerkship directors who are here, so that there's the same rules apply to everybody.
Dr. Carberry, just a potential thought is that it could be when students ask you what they should be wearing, it could be a topic of conversation, like where you don't have like these are the acceptable things that you could wear, but rather like, what do you think you should wear and why kind of question. And it might not be that everybody should wear the same thing. Like the goal of medical training is not so that everybody like looks, I think that's part of the diversity, equity, inclusion push. Like not everyone should like look like a doctor. A doctor does not look like one thing. Is what I would suggest, that there's some kind of like exploratory kind of like identity formation kind of process that should be happening, where people are kind of trying to figure out what they look like as a doctor.
And Abhishek has his hand up.
Yeah, I just, in thinking about this, and it's not, thank you for bringing this up, in that, so much of being a medical student, we try to make it as objective as possible with, shelf exams and objective sort of evaluations, but a certain degree of it is sort of your evaluations from your residents that you're working with or attendings, and you might, as a medical student, feel like they might be more likely to, like you or look at you favorably if you dress like them, which can be very different rotation to rotation, geography to geography. And I mean, not that a student should ever try to, fit in just for fitting in sake, but there's a financial component of that. There's a, anxiety component of that. I think it's a slippery slope for students that I haven't really thought that much about.
The next aspect of this, we kind of frame this talk, the entire session, as kind of going through your day. So you arrive in clinic, and then the first thing you do is introduce yourself. I think this is a big thing that students think about as well, is when you graduate, you finally get that MD, how are you going to conduct yourself? Do you go by your first name? Do you go by doctor first name, doctor last name? Who do you do it with? Are you doctor to everybody, or are you a doctor when you're with a patient, but with everyone else, nurses, MAs, custodial staff, schedulers, you're just a person, you're just, your first name. And why do you do that? One thing in my own life, this is another thing that I kind of started doing subconsciously, and I really only reflected on when we started thinking about this, was I would tend to I tend to go by my first name, but if things are going wrong, you know, there's a deceleration on labor and delivery, I walk in and I say, I'm Dr. So-and-so. And I think I was doing it both for me and for my patient, because I think it gave me confidence. And I think I was also doing it in a way to let the patient know that, like, there is someone here who has knowledge and training to help. And so that was one way that manifested in my life. I remember talking to classmates, you know, female classmates who said, you know, I'm always going to go by doctor because, you know, Nick, people are going to see you differently because you are a man than they will tend to see me. And I remember that's not something I had given thought to, but is a way that, you know, your professional identity is constructed. Anyone have any thoughts about this? I can also move on.
I can say I identify with this a lot. I always introduce myself, say I'm meeting a new patient in the office. I'm Dr. Holly Cummings. And some people take it upon themselves to then call me Holly, like straight back to my face, which it's always kind of confusing. I'm not going to like waste precious office time, but it's just odd. And then same thing, like when I sign the portal messages back, I think it looks weird to sign, you know, Dr. Cummings. So I'll write Holly Cummings, MD. So sort of my like full name and title kind of thing. And some people write back, Dear Dr. Cummings, and some people write back Holly. And it's, I don't have a solution for it. I've decided not to devote a lot of energy to it, but it's there in the back of my mind. I'm thinking about it, you know, and I don't know. I don't have a necessarily question or answer, just that thought.
Dr. Resber said, as a female physician and one that appears young for her age, I agree. I feel I have to be addressed by doctor in order to gain the respect of patients. I guess one question I have is, you know, obviously everyone will make a choice for themselves depending on their own personal experience, but would you counsel rising interns to do anything? Would you say, you know, I recommend that you address yourself this way, or would you just kind of let them figure it out for themselves? I think is an interesting question.
It's interesting, Nick, because I have a mentee who's at a different institution who prefers to refer to himself by his first name with his patients. And his educators are very uncomfortable with that, even though that's what he's comfortable with. And basically been told that it's unprofessional not to say, you know, I'm Dr. So-and-so. And I think, you know, the take home point for this, if you go back to your original slide, is, you know, finding out being you, who you are. I think we need to respect people for what they choose to do. So I just think that's an interesting aspect.
I think it's also important for you to be, yes, we need to respect for people what they do, but recognize that your choices have consequences as well. And you're not going to necessarily change the whole world in one encounter. Or so you can choose that. I choose to be called, I introduce myself to my residents call me Dr. Malone, they call Dave. He's the PD, I'm the APD. And that's just been the way that it is. And it's important for me that and then they become my partners, and then I kind of break them out of that habit. But it is important for me that they call me that, and that there be some level of the word, I don't mean to imply distance, but that there be a formality in terms of the relationship that people recognize kind of like my role in their lives in that regard.
Star Hampton said, I also think we need to be consistent in our choices and make sure our own implicit biases are not coming through with who we have / allow call us what.
Yep.
I think that's a great point.
Just one thought. Before people become medical students, obviously we all have a bunch of baggage. Like we all have a bunch of emotional baggage. And different people's emotional baggage is complicated. And then you bring that to the practice of medicine. And ideally, you're not like processing your own emotional baggage in real time with your patients. It's kind of like in the background or like totally not relevant. I think one of the benefits of a session like this is that people can kind of explore their emotional baggage. Like Nick and I did this session last year, and one of the fourth year students was crying, became very emotional, which is totally reasonable. I work with her clinically, and she's super competent and like really has her A game on all the time. You wouldn't get the sense working with her clinically that under the surface things are raw. And I think that there is space as medical educators to create safe space for students to kind of process these things that feel raw to them. It seems really, really, really simple, like what you wear, if you wear scrubs, if you go by Adam or Dr. Bruce, these things seem like they would be kind of superficial, but I think they really tap deeply into our sense of self. Yeah, just a little advocacy for this program in general of creating space for these kinds of conversations.
I think go ahead, Nick.
Oh, I was just going to say we are approaching time, and I'm really grateful for everyone and their comments. But we could go through this in so many ways. We have lots of different slides, but I think that there's two main things we wanted to kind of bring to the forefront. One, this idea of bringing intentionality to the way that we develop our practice on more of a micro scale. Not saying I want to be a clinician scientist, I want to be a clinician educator, but all of these little things. But then the next step of that is to what extent is it appropriate, or how do we counsel the people that we are responsible for teaching to do these same things? Myself for medical students, attendings for residents like me and fellows, to what extent do we direct people to or help them shape themselves? And so this is kind of our intent for this session. And for us, it was really well received. If anyone has any final comments or things that we could change about this, or things that you think that we're missing, we would love to know about that here or offline. You're welcome to email any of us.
Thank you. That was such a thought-provoking discussion. Really just thoughtful for us to even, I think, as attendees and as attendings and faculty, think about, let alone think about how we are wanting to teach that directly to our students and learners. So thank you, U of M, so much for sharing that with us. We're going to switch gears, and our next speakers are going to be talking about surgical education. So take it away, our second roundtable.
All right, I'm just going to take a moment to share my screen here. Okay. All right. So once again, my name is Abhishek Shripad. Thank you so much for being here. I know there are a number of really, really wonderful talks and roundtables happening right now, and I'm really appreciative that you all are here. The title of this presentation is Surgical Education from World Series Champs: How Shared Lessons Can Better Prepare Medical Students. Before launching into this, I'd like to just thank my mentors from my home institution, Dr. Hampton and Dr. Carberry, who are on the call right now as well. So I have no disclosures to report. And so what we'll kind of talk about, and my hope is similar to the last session, which was fantastic, is that this is certainly interactive, and I want to get your thoughts on the curriculum and how, other ideas for moving forward. But I'll just start with a little bit of the rationale behind this curriculum that we designed for our fourth year medical students who are going into OB-GYN, talk a little bit about the background between how we did that and how we pulled from a different industry, as you'll see in the world of athletics. Depending on how much time we have, I just have a couple of highlights from the curriculum itself, a couple of slides from each of the didactic sessions to just sort of give you a preview. Depending on how much time, we can certainly go into more depth, but I'd like this again to be very much discussion based to get your ideas and to generate future ideas. So the objectives will be to present this adaptable virtual surgical curriculum and very selfishly elicit areas for feedback and growth on this project, as well as to generate future ideas. So where this kind of came from is one of the things that we had identified as challenges for the incoming OB-GYN intern or fourth year medical student is there's tremendous variability in the experience that they may have. So that may come in the form of electives, either at home or away. This might be dependent on their home institution, their resources available for travel. And then, the structure of fourth year in and of itself, even pre-pandemic with traveling for interviews, I always encourage fourth year medical students to take some time away and recharge before the gauntlet of residency. So there's a tremendous variability and heterogeneity in the experience that students may have, particularly as they gear up for OB-GYN residency, whether it's surgical electives or opportunities for them to really get the fundamentals of surgery down. So, with sort of that mindset, we identified a few different needs. One being to equip students with the fundamentals to build on. So we all know that once you start residency, surgical experience is like drinking from a fire hose. Sometimes it's so overwhelming and so plentiful. What fourth year medical students may stand to benefit from is almost a categorization of how to process that in the subsequent, months and years as they start intern year. The other part of this was the need for a flexible curriculum that might help them do this. So of course, we are all virtual for the obvious reason of COVID. So this is more pertinent than a time than any. But in the mind of trying to increase equity and access to our medical students all throughout the country, and we felt like this would be something that would be beneficial if it could be virtual and adaptable for students. And then the last kind of corner of our rationale for this curriculum was trying to develop a longitudinal learning plan. So I think a lot of institutions, or most institutions, have some form of a boot camp or some form of a discrete learning session or time period before residency begins. And so one of the things that I kind of identified, and as we will see from our colleagues in the sports world, is they really have a longitudinal plan and way to track how their athletes are doing and sort of focus on areas that they can grow. So these were kind of the areas that we identified as needs for fourth year medical students pre-pandemic or right now. And I'd like to just pause and sort of get a lay of the land of how people are thinking about this. Is this something that anyone else has sort of thought about in terms of needs for medical students and how to better prepare interns as they start residency?
I have a little bit of a bias against the away rotations because I don't think that they're equitable in any way, because there's a large cost to students who choose to do them. A small portion of students get chosen to, and then those students make the assumption that they're automatically have an in to get a residency interview, despite being told that that's not the case. When you, especially in going to go off into a little tangent for 1 second, in an area where we're getting flooded with applications, like some of the students just aren't going to make it for the interview, but they assume that because they've been granted this, and there are lots of factors that go into granting away rotations, that automatically means that they're qualified to get an interview. So that's just my 2 cents.
Yeah, absolutely. And I think, one of the things that I was going to mention in a little bit, we've sort of gone through different iterations of this curriculum, but the first was a virtual elective for away rotators here at Brown for students of underrepresented minorities. And so, I think that whether this is in, substitute of an away rotation elective, I think that your point is very well taken about how, traditional in-person elective away rotations that may better position you for application season are not equally distributed. So I think that's definitely a broader need that we need to address.
And just one other thing, having said that, I also understand from the student's perspective is that with all interviews being virtual right now, the opportunity to get into an institution and get a feel for that is taken away to some degree.
Absolutely. Any other thoughts surrounding that particular point about unequal access to the opportunity for away rotations, or sort of just general challenges of preparing fourth year medical students from a surgical perspective? All right, well, we can move along. So, as we kind of were thinking about a curriculum and some of the needs that our students may have, we noticed that, COVID presented a lot of challenges to a lot of industries. And, one that we identified was a parallel challenge in the athletic world. So, March 2020 was an interesting time for a lot of people, including Major League Baseball. So the season in general, for those who are unfamiliar, sort of starts in the early spring and runs through late October. So the early spring being right when the initial surge happened. So typically that's where spring training happens, which is a time period of training where teams regularly undergo training in the fundamentals. Of course, these are professionals, but it's really a time for teams to identify areas for growth and team strategy and honing their fundamental skills. And so it's a very important and impactful time for teams as they start their season. Of course, in March 2020, everything became virtual. And so these teams that often relied on players flying to either Arizona or Florida for a month-long in-person training session ended up having to adapt and do it virtually. So one of the kind of fortuitous things in my life, one of my close friends is part of the Los Angeles Dodgers organization, and he was part of the team that came up with their kind of virtual training strategies. And so they use a multi-pronged approach, which interestingly, some of it is very similar to what we do in medicine with sort of case-based presentations. They would do, situations where they would train the players of how to think or how to react to situations. But one of the things I thought was particularly fascinating is they relied on video-based submission. So they would have players, videotape themselves either pitching or hitting or whatever their skill set was. And they had specific technology to really break down the components of what made a good pitcher or what made a good hitter. So this became very granular, and I've just kind of listed some of the things that they looked at here. For pitching, for example, they evaluated the velocity, the spin rate of the ball, the direction of the spin. For hitting, it was the exit velocity off the bat, the launch angle off the bat, the exit direction. Now, I'm not in any way qualified to extrapolate what any of these things mean, but what they sort of designed their coaching from afar for was to improve these individual components rather than what they would traditionally base their coaching off, which was, general competition against other teams or scrimmages or things like that. And so while we sort of exist in very different worlds, the challenges are kind of similar in a sense of when you're training fourth year medical students to either get basic surgical knowledge or skills, we generally rely on sort of in-person teaching, whether it's formalized or informalized. And those are similar challenges that the Los Angeles Dodgers and every other team experienced as well. And ultimately, they did it as good as anyone else as they won the championship that year. So we designed our curriculum. Of course, we didn't use exit velocity or spin rate or anything like that, but we broke our individual components into the principles, techniques, and anatomy of gynecologic surgery. And so these three sort of pillars formed 3 different didactic sessions that were anywhere from 20 to 30 minutes and all virtual. And again, the highlight of this was to make things as adaptable as possible. So I'll pause for a moment and just explain the first iteration of this was with away rotating students virtually from different institutions in our underrepresented minority elective a couple of years ago. Subsequently, this year, we've done so with our own Brown students in its current format. And so this has been pretty successful in having students be able to make it, given they're interviewing, even though they're not traveling. It is hard to find time between these virtual interviews that students are doing. And we followed up with 2 application sessions. So what this meant was we would watch surgical videos and ask the students questions at different times within the categories that we previously went through. So the principles, techniques, and anatomy, gynecologic anatomy. And so based on the students' performance, we've sort of helped generate different types of learning plans that they could potentially, follow through and work on. We're in the process of figuring out how to sort of assess how well that works at the end of the day. So these are just curriculum snapshots, but I just want to pause and see if anyone has any thoughts or questions, things that you've tried at your home institutions that may mirror something like this. Just want to open it to a little bit of discussion right now before showing you a bit of the curriculum.
Are you saying that you would have a faculty member watching like a surgical video of a GYN surgery, and then you would be like asking questions as the video is playing to a subgroup of students that would sort of all be on a chat together?
Yeah,
I'm just trying to understand a little bit.
Yeah, absolutely. So the format was such that we would all be on a Zoom session like this, and it was myself who we would play a surgical video, and there's very set sort of points in the video where we would pause, and I'll give you a sense of what those questions might be like. But that's where we would pause and ask the question, what's this anatomic structure, or what type of instrument would you want to use in this situation, or questions like that may that would have gone over topics that we had covered before. So it would be sort of a live virtual session where all the students were on that particular call, and then they would submit their answers and we'd get them to sort of chart their progress. Does that help clarify that?
Yes, thank you so much.
Sure. So these were our objectives of the that we presented to the students, and it is sort of echoing what I had said before, but just to be familiar with some basic principles and surgical techniques. We used an APGO approved basic anatomy slide deck that the students had to pre-read, and then we used that as sort of an interactive anatomy lecture. And then our goal was to help them apply this knowledge in our application session. So this is an example of the type of kind of information that we covered. So this came from the principles didactic session, and this was just a brief slide on different type of clamps. Although you can see some of the details of names of clamps and things like that, the goal was really to help the students think through what type of clamps are available for different portions of the procedure. And that's the type of thing that would be tested a bit later on in the application sessions. Similarly, we, students seem to have a pretty good understanding of what the names of different sutures were, but what was helpful was to focus on broader principles to help them identify why different sutures are used at different times. Similarly, when we talked about techniques, this is from another APGO resource, we would help them understand sort of what dissection techniques were available, when you would use different types, and then this would be something that they would apply. We would pause surgical videos and sort of brainstorm how they might be able to access different types of surgical planes. And students seem to really retain this type of information, which I think they really enjoyed to apply during the videos. And this is just kind of another example of the type of information that was covered. Additionally, I mentioned that we went through some anatomy slides, and these are just representative slides of a couple of that particular lecture. We had them, in this case, look at a small PowerPoint beforehand. So everything on this particular anatomy slide was sort of question and answer, and we would go through the answers with sort of more detail versus the PowerPoint that was presented beforehand. And so just to sort of give you a sense of what things looked like at the end. So this was sort of my own document for myself. Using an abdominal hysterectomy video, we would have specific times where we would pause, and then the type of question that was asked definitely had a category assigned to it, either in anatomy, technique, or principle. And this was charted with regards to each student's performance throughout, so we can get a sense of which students were doing well in anatomy. Maybe they needed a little bit more guidance or resources available to them, videos and things like that. So, I'm happy to go through a little bit more in detail the actual curriculum in a different slide deck, but I wanted to kind of open this up. I think a challenge that we're all facing, particularly with COVID, is trying to adapt our traditional techniques into a virtual format or as socially distanced as we can. I think one of the interesting things from our particular curriculum, but I think a whole sort of area that we can learn from is how different industries are sort of adapting what they normally do in person. So I just wanted to open it up and get a sense of what people's reflections are, some of their frustrations as this is sort of unfolded over the last almost 2 years now. And yeah.
One thought that I have is just when I was a learner, it was helpful to do something like this right before going into surgery. So you're about to go into a TAH and you can kind of review what a TAH is like. And so it sounds like you did this in real time, but there's potentially room for like an asynchronous model that you create these modules and then somebody kind of is like, oh, tomorrow I know that I'm going into a vag cyst. I can like run through this. I even picture like, part of the benefit of real time is that there would be pauses for conversation, but you can almost like, there's models of this, not to make a joke out of it, but like Blue's Clues has that model of like children's programming has that model of like you pause and you create space and then the student can have time to reflect kind of thing.
That's definitely, that's a great point.
But it would allow somebody to kind of use there's obviously benefit to doing this in an organized way, but a lot of the learning happens randomly. Like one person goes into a vag cyst, the other person goes into a TLH, the other person goes into like a BSO.
Yeah.
And obviously like having the ability to reflect right before would be really cool.
Yeah, that's a great idea. Thank you, Dr. Berger.
I think this is really cool. One thing that we're starting at my institution is trying to look at surgical coaching, video-based surgical coaching. The idea being kind of as we were talking about in the last session, like we learn as students and residents, and then we go into our own operating room silos. And I very rarely get to operate with another attending. But we all have tips and tricks that we can share. And now that we are so much in an era of laparoscopic or robotic surgery, there are a lot of videos that we can record of ourselves operating. And then there are a couple, there's one faculty member and one fellow who have volunteered to sort of coach the residents, but have also opened it up to the faculty that we could watch our own surgical videos and go through sort of a guided discussion. And I really like that your curriculum is almost very similar, but at a learner appropriate stage that maybe it's a more standardized video, or obviously it's not them doing surgery, but you're still using video to really teach the applications of surgery, which I think is really cool.
Thank you for that, Dr. Cummings. Yeah, I think one of the challenges with surgical coaching is the time investment needed, particularly if it's at an attending resident fellow level. Sorry about that. That's required for the evaluator. But I think there's a tremendous opportunity, like you said, a little bit earlier on in somebody's training, like medical students, that the sort of necessary investment for the evaluator isn't necessarily as high. So I think one of the things that we've sort of thought about is how we could incorporate actual skills into this. And I think just for this particular curriculum at its current iteration, it was just a lot of time investment that it would have been hard to organize. But yeah, I think there's a momentum for this everywhere.
Abhishek, I was going to ask you, in our clerkship with everything being virtual, it has been really difficult to get students engaged as much as people try to do that via Zoom. I hear constantly from my faculty that that's just an ongoing challenge. I know you were dealing with a small group and they were the same people and they were obviously interested, but do you feel like there were things that you did that really helped it be an engaging process?
Yeah, that's a great question. I think this was a little bit of a pre-selected group in the sense these were students going into OB-GYN, but even within that group, there were students that never missed a session, or if they missed one or two for interviews, they, let me know ahead of time. And, I think that's normal variability amongst, students and human behavior. I think the, thing that I found that students responded to was, I sort of did all the sessions so I could remember what they, maybe got wrong the last time and be able to sort of validate their growth. And I thought that sort of longitudinal attention to their learning plan was very helpful for them. I think as a medical student, as a fourth year, you're focused on, getting into residency, and, your learning is kind of individualized in its own world. It's almost helpful to have sort of a sponsor or a champion of that when, you do have have some growth in a very tangible way. So. I'm just going through the comments right now. A couple about asynchronous learning. Perfect. I'm not familiar. Dr. San mentioned articulate rise. I'm not familiar with that particular assessment.
It's just that, you know what, it's a really nice way. It does cost money. So as far as I know, there's not a free version, but it does. And there's two different ways that Articulate can work that I'm aware of. And I definitely don't have any funding from them whatsoever. But our school actually decided to purchase that with so much going into the asynchronous world, whether it's pre-clerkships or during clerkships. But I was actually thinking before they did that I might even just purchase it on an individual level. They just make it really interactive. So it's used across many different industries, but you can create any type of module. It's very point click intuitive, and they have different mini assessments that keep that learner engaged. You can insert videos into it, but it basically runs in a way that it kind of looks like either a slide deck or can be something that's like a chapter book almost, but an online chapter book, and you're going through different sections and segments. So just putting that word out, since it seems that the nature of your discussion is really nice when it comes to thinking a little bit about what does that online or virtual world look like. I'm curious, Abhishek, are you thinking as we enter back into sub-I times and rotations or thinking about them, planning them for this coming year, are you guys going to actually still offer virtual options? Is that something that is because of whether it's equity or just because it works so well and you found a way to make that happen? Is that something that you guys are continuing to plan for and do?
I'm not sure in terms of the kind of medical school's plans for those types of things. I don't know, Dr. Carberry, not to put you on the spot, but do you have a sense of what, in person versus virtual electives in the future for, medical students outside of our school?
Yeah, I mean, I think we implemented that in 2020, and when we tried to look at it again and kind of go back over what worked well and what didn't, we did. It was a lot of discussion because, to the point that David made earlier, there's a big question about equity and how to make this fair and not inadvertently give opportunity in a way that we don't want to, but also provide the best experience. And people are very hungry to see institutions and work there in person if possible. So when we started to have with the next cycle of rotations, we were able to have visitors, so it became a tension about like, what do we offer, and so we ended up offering both, and we didn't get a lot of interest in the virtual, which was kind of surprising to me. Actually, I thought there would be more, but I think we're going to keep trying and seeing. And I think what you've done with our local our students at Brown is also still something feasible, because as you mentioned, these students are interviewing, and some of them are not here anymore. They have gone home to where their parents are, and they've been doing all of their stuff from there, what have you. And so I think being able to offer something that's not necessarily physically in person is going to continue to be helpful.
Perfect. Well, it looks like we are just about done with our time. There was one quick question from Rebecca Franklin. with the students, the question was, did the students video themselves suturing? Unfortunately, in this one, they did not. We talked about suturing, but we didn't get live or video assessment. So that's about all the time we have. Thank you everybody so much for your engagement. And I'm happy to hear from anybody with comments or questions or just to continue the discussion. So thank you.
Absolutely. Thank you. Thank you, Brown. And thank you, University of Michigan. These were really thoughtful discussions. And don't forget that you have the community section in Whova, to be able to connect with our speakers if you want to continue some discussions and questions. Thank